Hello, everyone, and welcome back to another episode of the IDRiM podcast. Today, I've invited a very special friend of mine, who we've known each other about 7 years now, haven't we? Used to, so, um, for me, she needs no introduction, but I'd like to introduce Kalia. Kalia, like to introduce yourself?
Okay, what would I say? I'm Kadia Suzanne. I'm an epidemiologist with a background in emergency management, and my research interest is really geared towards displacement, emergency response, sexual and reproductive health, and gender issues in conflict settings. Yes, that's basically it. I run a small organization in which we try to empower uh, community host communities of displaced persons to reduce to increase social cohesion and to also uh, facilitate reinsertion of displaced persons. Yes, so that's what I'm focused on right now. Thank you.
Thanks, Kalia, for your introduction. And today, what we're going to focus mostly on, because you've got a wide breadth of experience and knowledge. But what I wanted to focus on today is your paper you published back in 2023, and and the paper was about the usefulness of disease surveillance data in enhanced early warning of the cholera outbreak in southwestern Cameroon in 2018. And actually, as we go through, I'm hoping the audience will start to realize actually some of the themes that come out of this are very similar. Um, Not exactly the same, different disease, but to what is currently going on in the DRC with the Ebola outbreak. So and we'll probably get onto a little bit of discussion on that towards the end. So first of all, and I like to do this as a icebreaker for any research. What first drew you to study cholera surveillance during the conflict in southwestern Cameroon?
Okay, so at the time I was thinking about what I will work on for my master's thesis at the Northern University. And I had a lot of challenges. Initially, I was thinking about working on something that had to do with sexual and reproductive health, but at the time, the COVID 19 was just made everything not possible. And so I found myself uh, getting the information on how our health system was being broken down by this disease. And I wondered, we experienced this disease way after other countries. We had all the tools and the resources to be prepared, yet it was so devastating on our system. So I really wanted to understand what was it that wasn't right. And uh, one thing that creates a really robust system is well-sourced data. And I realized that a proxy to understanding how our system receives information, processes it, and is able to utilize it to prevent such breakdown of a system in cause of an outbreak or a pandemic will be to understand how we generate data, will be to understand how we use data, how we store data. So the dynamics around our data. And I decided to use cholera because, in Africa now, we experience a lot of conflicts, a lot of disaster shocks, and this, unite in a very quick way elements that lead to cholera in particular, displacement, poor infrastructures, lack of staff. All these things are very are raw materials for cholera cholera outbreak to happen. So I said, okay, let me use this data to understand the system and to, recommend what we can really do to fight such diseases.
Yeah, and I remember your cohort because, so disclaimer, I used to actually provide help to the Masters program at Northumbria back in the day. And I remember that year and how everyone panicked because they couldn't go and do research in the conventional way because data, and actually made a lot of people rethink of what data represents and means because it meant people had to actually start reusing data rather than the creation of data. So it was actually I always found it was quite an interesting, year because actually it was some of the better projects, if I dare say it now openly, because it actually basically took valuable data and actually give it a new life and purpose. So, and it's quite interesting actually when I was listening to you talk about it, there I could see actually how much that really this you found this actually quite a useful experience to reuse data that actually anyone could really go and have a look at. Let's talk about what is going on in the ground. So for listeners unfamiliar with the situation, can you describe the political, the social, crises that affect the everyday life and health system in this region of southwestern Cameroon?
Yes, all of this started in 2016, and it's a very polarized topic here in Cameroon because, in spite of the many consequences that we're living now, at the beginning, people didn't really foresee that it would have this crescendo, devastating effect on various systems, especially the health system. So it's a conflict between the some armed conflict between the government and the unknown armed men. They are called Amber Boys, if I can say that. And so this group of people are really trying to put ahead their case of Anglophones being marginalized and not given the space and the opportunities that they are deserving. And it quickly escalated into a non-controllable conflict that affected not only families, but them and education. It had a devastating effect in the Southwest region. And we started seeing that a little while after the conflict, not after, a little while after it started in 2018, with diseases resurgences like cholera. It'd been a long time that would not had cholera outbreaks in the Southwest. It's also worth noting that the Southwest region is one of the cleanest regions in Cameroon. However, with that conflict, we started seeing the resurgence of waterborne diseases, the resurgence of other infectious diseases, and that was primarily due to the breakdown of infrastructures and the lack of access to information that can help the population to know how to navigate a conflict while taking care of their health. So basically, in the Southwest region, you see people not being able to go to health facilities, people having to revert to drinking not so potable water because they have to protect their lives. They can't just be moving out. And yes, the food quality reduced. So everything was going downwards. And it's a lot better now. But at the time, you couldn't even go to the Southwest. You couldn't even go to the Southwest. But it's a lot better now. And we lost a lot of lives. We saw a lot of healthcare workers running away from the Southwest to, regions where they could keep their family safe. Yeah.
Yeah, and I mean, I think, correct me if I'm wrong, but the conflict is now like a low level style conflict. It's still there, but it's not as intense as it was back in 2018. Yeah, I can see you shaking your head, saying yes, nodding along there. So yeah,
Yeah.
um, So, just think about cholera, and cholera is quite an interesting one because I think people underestimate cholera in terms of it's how debilitating it can be. Actually, how weirdly it's easy to start developing in any context. You'll have had the same lecture because we both have had, Professor Andrew Collins. We've both been under him as students. And one of the things he used to teach us very early on in disease control is that cholera even lives still in the Tyne River, that goes through Newcastle. So he kind of uses that type of analogy to say it's everywhere. If you don't manage it, it's gonna come out of control. Um, so why is cholera such a revealing disease to study in conflict settings?
Yes, it's for several reasons. For several, primarily because of how rapidly cholera spreads, how rapidly it spreads, and how little it needs. The condition for cholera to spread are so easy to unite. So it's the surveillance of cholera has to be very sensitive. The system has to be very sensitive to catch up with suspected cases as soon as possible so that you can contain the disease. And you see, health system, normally very robust health system, when they start experiencing disasters, maybe like floods or conflicts or climate changes, the first thing that they do is to prepare their health system to capture these diseases that have the potential to create rapid epidemics in a very short period of time. So their systems are able to capture that. But you see that it comes with a lot of resources. It comes with a lot of resources. So countries that lack resources are at a disadvantage, and they will gain if their system is more proactive rather than reactive. Unfortunately, that's not the case. Our systems are very reactive, and so we don't prepare for such things taking us by surprise. So really, cholera is an important proxy of seeing how robust a health system is. If your system can manage cholera outbreaks, you're doing good. You're doing good, especially in a low income setting.
Yeah, and cholera. It's very common you see cholera after any style of disaster. I mean, like I said, it can happen in any country, any context. If, as you said, the conditions hit that right condition for it to happen, you're then playing a game of catch up rather than being, than preventing it. Now, in your paper, you frame disease surveillance as a part of early warning systems, and what does early warning actually mean, in public health? Because, at the minute, this is a key question, not just for Africa, it's for every country. And we've seen how, sometimes we haven't had them systems in place, and then we're being reactive. And as you mentioned, reactive is if for cholera, it's pretty, it takes a lot of time to catch up. So, what does early warning actually mean in public health?
Yeah, early warning, it's really the ability of a system to anticipate possible outbreaks, to prepare for it, and to prepare proactively for that outbreak, to have everything in place, making sure that if there is a likelihood that this disease can occur, the system is able to contain. The system is able to make sure that the casualties are so minimal. So the disease surveillance system is an example of an early warning system that is peculiar to the health domain, in the sense that they have diseases. It's very well structured. they have diseases and their threshold of alert. Their threshold of alert, and you have a very structured way of reporting those diseases in such a way that it can allow us to inform decision makers, and for these decision makers to make decisions that help the system to anticipate outbreaks. Yes, so that's basically to anticipate outbreaks and to respond appropriately to those outbreaks. So there are various stages of this disease surveillance. You first of all have the case identification, and for the case identification, the case identification has to be as sensitive as possible so that we can get as many suspected cases as possible. Then from there we filter and we can be able to get confirmed cases. So the case identification also has to be contextualized. For instance, you cannot go and put a case identification definition of a disease that the community is not able to understand what you're talking about. The terminology used have to be one that the community can detect that from their household. So in cholera, you need to have a good communication with the community. Together, you people define what they understand by cholera, how does it manifest in their community, what are their lifestyle habits that predisposes them to get a cholera contamination, and all of that enters into the case definition, which is then disseminated all over. And each time that a suspected case, there are symptoms, signs and symptoms that the expert looks at. And each time that you see one of those signs and symptoms, you are obliged to report it through the reporting circuit. And it is there's a validation process that takes place. And if it is validated right up to the laboratory where it is confirmed and the Vibrio cholerae is found in the sample of the target where it was reported, then there is one confirmed case of cholera, and this is a national public health problem. There's a national alert, and you say the country is under a cholera outbreak. So that's how the disease surveillance work to alert in an early way any cholera outbreak.
Yeah, and when I was listening to what you were describing, that's exactly what is happening right now in Congo, DRC, because so I've been following this myself, through BBC World Service, and you hear about these initial in cases, and then trying to you know tell people what to look for, what all the important things we do with the disease surveillance. One of the things that's come up in the DRC with Ebola, and I'm wondering if the similar thing with disease surveillance has happened in Cameroon with cholera, was that issue of trust with local communities, and because sometimes communities who have felt undervalued for some time, and seeing these people, doctors coming in, talking about diseases. In this context, was this a problem? Because what we're finding, in particular, in a lot of contexts currently in DRC is there's this don't trust. But don't trust, what, the experts, but don't trust. And it's taking longer than we need to develop that trust in that community, at which point, we don't know how many people have been infected. So in Cameroon, was this a similar style of issue?
Yes, yes, it was. You see, what you're saying is very interesting because if you look at the pattern of outbreak of 2028, you realize that where it stemmed from, it's Bakassi, and Bakassi is the Bakassi is a district that is surrounded by water, so it's a hard to reach district, and their realities are quite different from the other district, the other urban districts. And even to go and collect data there, to go and collect data there is a task you need to take time to plan. But they are the most likely to have a cholera outbreak. But because of the nature of the place, attention isn't given to them. So you will see in this in the paper that was published, the paper that we published, you realize that the key informant said that when they had to go to Bakassi, they realized why Bakassi always sent data late, why they had a very low timeliness in sending in their data, and their data was hardly complete. Be, because first of all, they don't have the health infrastructure, they don't have the staff, nobody wants to go and work there. And the few personnel that are there, they do so much work, they are burnt out, they are demotivated, people don't come around to see them. And so that key informant said, when I went to Bakassi and I saw their reality, I became so patient with them. I realized that, so this is what is happening. We need to gear our efforts there. So the people in Bakassi really matter because they need an epidemic for the country to get the attention of the country. So it is kind of difficult to win their trust at that time because you have a limited time to act, but you have to do something delicate, which is to win their trust. How do you go about that? So those are some of the subtle things that could enhance early warning of outbreaks if we have the buy-in of susceptible districts, susceptible target population. The other one too is the community lifestyle, with the Muslim community, the way they process, the way they live predisposes them to cholera outbreaks in some communities. However, there are not targeted health risk communication to that population. So they receive the same communication that the urban community receive, that other people receive. So they don't know that they are putting themselves at risk. So those are some of the challenges you mentioned that, increases the risk of a cholera outbreak.
Yeah, yeah. Thank you for for explaining that, because I think that is something that is often overlooked in disease control. I mean, I think that when we talk about disease control, we automatically, I think a lot of people automatically assume that if there's a disease, we go in, we fix the issue, and we go back out, and that's not the case. And it is why it's why we get epidemics and endemics in countries, because by the time that we've built that trust, it's already spread more widely, and that
Yeah.
makes it a lot harder for us to try and get into the containment phase. Because
Yeah.
I mean, right, it's basically what happened in Sierra Leone back in 2016 with Ebola as well. Same
Yeah.
same problem. It took so long, and then it took about a year to basically, and it spread to 3 other countries before we could actually put a lid on the outbreak, because it takes weeks to develop trust, if not months. And in diseases, we don't have weeks and months, we have days, and that's the bigger issue. And so, I mean, you also mentioned about data as well, and the health data, and your paper showed that conflict intensity correlates with poor reporting, of the timeliness and completeness of data. Was that actually to be expected, or were you surprised actually by how strong the relationship between these two variables were?
Yes, yes, that's an interesting question. And I discussed this with Professor Andrew, and you see, that's what we expected. Normally, they expect that during low conflicts, during low or medium conflicts, you would expect that the reporting will be adequate. And during high conflict, that's when we'll have problems like that. But there's a nuance because during high conflict, we had districts that were still able to submit their reports on time, and these reports were complete. And when we look at those districts, their characteristics are, first of all, that in proximity to the site of reporting, so that in proximity to the region, they are usually urban districts, and these urban districts have the manpower, they have the infrastructures to 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 be able to do that, but most especially the finance. The finance shall back up to be able to do that. No matter how good your intentions are, if you don't have a financial backbone to support that decision, then it's of no use. So those districts that were able to perform well during high conflicts were of interest to us. And these districts were that were in that category were under a performance-based finance scheme, and this allowed them to have funds, to be able to take care of emergency situation. Generally, if you look at the other aspects of my study, we highlighted that the system was very centralized and there was a lot of bureaucracy. But in districts that have the finance, they are able to bypass all of that and focus on the emergency. So there's a big problem with funding. There's a big problem with funding because at times the funders, the priorities of the funders don't align with the priority needs of the community in which the intervention is done. Yes. So it's something that is not usually taken into account. And you see it very glaring in the reporting, the online reporting system. You see, our conclusion was that it was erroneous because they will report 6 cases of Ebola, 6 cases of plague, but those cases were not true. They didn't happen. And that was a lack of a data validation process, a data cleaning process. Those things are not processed. So if the funder wants you to build a reporting system that can be online, they will do that, but they don't look at the quality of data that is generated by that. So you as a tourist, if you intended to come to Cameroon, for instance, and you go to our district health information system and you navigate, oh, what are the diseases that I should look out for when coming to Cameroon? And you see 10 cases of Ebola, 10 cases of plague, and you start wondering, no, no, I shouldn't go there. So you see that it affects even the tourism sector, it affects so many other sectors when funding is not uh, uh, is not structured in a way that responds to the need of the community. We start getting things like this.
Yeah, and I'm guilty of that as well. I do check health reports before I do go to anywhere. Um, I'm just thinking as
Yeah.
well. Um, so this whilst doesn't tie into your paper exactly, because I know that the issue of funding for health is becoming a bigger debate right now, and I'm just wondering if the African CDC having those now, having that center available is providing additional help, additional resources in times of crisis because it was set up in 2016 and it's managed already a few big outbreaks. I mean, it's managed COVID, it's managed the Mpox outbreak, it's currently managing the current Ebola outbreak in DRC. So I'm wondering if that is going to help this process to make sure that there is more financial resources in times of there is an outbreak of some sort. In Cameroon, if another cholera outbreak, you know, did happen, that they would be ready to be deployed when needed.
Yes, the African CDC is doing tremendous work in Cameroon, especially in terms of surveillance. There are other there are other organizations too, the World Health Organization, you know, UNICEF, that there are a lot of organizations that are supporting the disease surveillance system in Cameroon. But one thing that is really sad is the question of sustainability. Is the question of sustainability. That's why funding and sustainability are very current questions that should be addressed when we are receiving external aid. Because at the end of the day, we're not going to depend eternally on Africa city on the Center for Disease Control. Our Ministry of Health should be able to take up that task, and then we have local organizations support our Ministry of Health, not always expecting external help. Because, to be honest, some of that help, well, most of it comes with strings attached, and you never really know what strings are attached to that. You don't know what you're foregoing by accepting such help. But of disease in the domain of disease surveillance, it is important for us to think about sustainability and to address things from the grassroots with the community, to contextualize our interventions such that when there can be a smooth transition between the international donors and the country. That's something that I believe struggles. African countries struggle a lot with the transition with international organizations. And you see, when that transition is not well done. Oh, so I was saying that when that transition is not well managed, you see the resurgence of diseases that were either contained or eradicated, like the polio, cholera, and all the like. So many factors, non-clinical factors, can favor the occurrence of cholera. And what is interesting is that we can control those factors, but at times it's very political. It's very political.
Yeah, and what you also mentioned there about attached help, from external agencies, you'd hope that that didn't happen because, I mean, at the end of the day, disease surveillance in particular is, it's not a local national issue, it's an international issue because we've seen how diseases, in recent years, COVID-19, Mpox, we've seen these diseases that have came out of different regions, and have spread it amongst communities, more internationally. And at time at this minute in time where international aid is getting, cut, and obviously some countries are putting more and more, strings attached to it, it boggles the mind why, because at the end of the day, if we have another outbreak of a disease like COVID, surely it's in our interest to spot it before it happens, in a significant way and stop, because I think, the amount of money that the world society lost in 2020, 2021, we could have spent on, preventing these diseases. And it just, I was listening to you then, I'm thinking, why are we doing this still? Why have we still got such an old, outdated view of health and how, when we are basically now one big community where disease, spreads much faster than it ever did.
Yeah, yeah, you're so right. I really agree with you that diseases it's not localized. It's something that should a disease affecting a certain country should be the concern of the whole world. Should be the concern of the whole world. But where am I not necessarily converge is the aspect of how they go about it. How they go about it, because at the forefront of it, you are seeing we are all interested in eradicating this disease. But we can also look at it that that is an opportunity to empower communities where these diseases come from and allow them to be able to capacitate them to be able to respond to that in a durable way, but that dependency is always created. That's where my problem is. There's always that dependency, and how long does that have to take place? Like our parents, our grandparents depended on the funds of CDC, depended on, for all these years, we are still dependent on funding, huge funding for our health system. It's true, all health systems depend on some level of funding, but in African and low income countries, it's quite huge. It will be very debilitating if external fundings were withdrawn at some point for Africa. Very, very debilitating. But at the end of the day, shouldn't we be able to have stepped up for all these years? So what's the bottleneck at this point? Those are some questions that
I would say
I can say that we're looking. Yeah.
I don't think even I can answer what are the bottlenecks on this case. So we'll move on. You mentioned that health in your paper again as well, but health workers themselves become targets during the conflict. Now, we've seen this, in different conflict zones. Where the outbreak at the minute of Ebola in the DRC is an area that health workers don't really want to go into because of, they are at risk. We've seen it in the Middle East as well, in Syria, health workers, were at, risk in 2012 and 2013. And I think it surprises a lot of people that is the case, because we think of, in previous conflicts where that usually there's like, you don't touch healthcare workers, but it's seemingly that this is now an increasing issue. How does that fundamentally change, the response to an outbreak? Because I imagine it depending on, obviously it'll depend on the individuals, depend on the organization, but some probably, I would imagine, won't even go into certain zones, which creates bigger problems down the line.
Yeah, that's very true, and that's a pattern that we've observed during more recently during conflicts, very lawless conflicts, and you see, healthcare workers are targeted primarily because health is the vein, is a nerve of a country, is the nerve of a country, and to maintain a certain geographical advantage, the adversary party needs to have leverage on something. So by attacking healthcare workers, they put themselves at an advantage. They put themselves at an advantage. Some even use the healthcare workers to be able to take care of their wounded team members. So healthcare workers are not only targeted in a way to weaken the government, but also they are kidnapped and held captive to take care of the other fighters. And it's usually in areas where the government doesn't have geographical advantage. When a country is at war with itself, one thing that you will see very common is that the parties that are fighting with the government, they they come from the communities. They are not external people. It's not another country fighting in your country. Those people come from the community, and they have that advantage that they know the ground. And so the government cannot venture into certain areas because those people have a clear mastery of it. The other thing is they don't have the knowledge when it comes to health that the government may the government entity may have, and so they themselves are at risk of spreading disease. The population is at risk because they don't get the information they need. The government lacks geographical knowledge to understand where the population is being displaced to in high risk zones. And those high risk zones are where cholera outbreaks emerges. So it's a very you need to be very strategic in the way you look at it when you're trying to circumscribe where the cholera outbreak starts from, and it has a lot of consequences because of, you spoke about international transfer of diseases. Cholera is one disease that is a transborder disease. You see people moving from one, you might think that this case started maybe in Bakassi, and before you know it, that case is has moved to another district, The kidnapping of health staff, the few staff that are there are overworked, and so the quality of work reduces, which increases the likelihood of the spread of the disease too. So it's a very interesting question that you asked.
Yeah, and I mean, I just think of, in the context of, conflicts that have happened in Europe, I would say, one of the bigger conflicts that happened in Europe, apart from Ukraine, which was a low-level conflict, was in Northern Ireland, in particular, and it was an unwritten rule, in the Troubles, that you don't attack certain groups, and this was one of the groups that you do not attack because it's it's a red line. It's
Yeah,
not it's not accepted by the community that you attack these, people who are trying to help both sides of the community, no matter what part, which side of the conflict they're on. So I mean, I think that's what frustrates people, and confuses people from places like in the UK, where there is this mentality that you don't, that doesn't happen. That should not happen. Having said that, whilst it's not conflict, during COVID, we did see attacks on healthcare workers, and that kind of shows that even now in Europe, these types of issues are becoming to the forefront because of this trust issue, and it was a trust issue that was the problem in Europe. I'm not going to say, on the podcast, certain slogans or things that they were doing because it was vile. But yeah, it's now an issue that seems to be even just it's like I call it like a disease itself, where it's now spreading into different places where
yeah,
these types of things shouldn't happen but are happening.
yeah.
Now, your paper describes, and I've kind of touched upon this already, how healthcare workers were afraid to even travel or conduct field investigations. I kind of already answered this question, but how common is this problem now globally in conflict zones? Because I see it quite a lot, from what I can, as an observer.
Yeah, it's very common. It's very common. Um, in our communities also, it's not very, it's rare to see that bravery to go into, the communities and decide, have that sacrificial spirit that I'm going, these people need me, I'm going into the field to support during conflict, and all of that is kind of difficult from the side of the healthcare workers, because in Cameroon, the way healthcare workers are distributed, it's not always autochtones. That autochtones means like people born in that area that work in that area. So they're usually people from different areas that are transferred to go and work in a certain district, in a certain town. So when you go there, you are not from that area. That's not your native land, your village, as they will say. And so they are limited. You cannot take some sort of initiative because you don't master the culture, you don't master the norms of the community, you don't master geographically the community. So you don't want to put yourself at risk in a way that all of that will go to waste. All of that will go to waste. Another thing that is a crisis at the moment in Cameroon is the wages for healthcare workers. Healthcare workers are very poorly paid. And if you look at the statistics at the time of the conflict and at the time of the COVID and the cholera outbreak, you'll notice that there was a lot of brain drain in terms of healthcare work in Cameroon, flying out of the country to developed countries for greener pastures. So you see that the number of healthcare workers that are even left are few, and the few of them have so much to do. Look at, we're discussing about the data, and one of the fundamental thing that this study brought out was the most parallel multiplicity of reporting tool. When you are work that has to be done by 5 healthcare workers, it's just one person that is left, and that person needs to fill a paper form, fill an Excel sheet, and fill a DHIS online software. All that the person is entering the same data. You'll be burned out. He'll be burned out. At times, that's why you see at the end of the day where he was supposed to write 10 diseases, maybe in malaria, he's going to write it in Ebola, because you cannot guarantee the quality of work when the fundamental workers do not have that environment, do not have that space that can allow them to perform. They become demotivated, and some of them derive a parallel way of having money that is detrimental to the system, because they have been pushed to the wall. The money, the wages that they get cannot sustain them. And when they engage in such parallel activity, it affects the disease profile of the country. It affects the disease profile of their town. It affects the disease profile, especially during conflicts.
Actually, that raises another question. How many hours are these healthcare workers actually having to work a week? Because I know that in the UK, there are time limits on how much you have to work. You can absolutely work, but to stop the burnout, as you mentioned. So how many hours would these, healthcare workers be expected to work?
Normally, they should work 40 hours a week. That's what is, on paper, theoretically. But in practice, that's not what happens. That's not what happens. You see, a single staff has to assume the position of the statistician, the data manager, the chief bureau health. A single staff has to compile reports for 4 health programs and submit it within a specific deadline. And if you're counting on that particular staff to report, to capture data, emergency data, and report it within a specific period of time, you see that we're lagging behind. Take, for example, this cholera outbreak. After the sample of a confirmed case is collected, it has to reach the central level within 48 hours. Within 48 hours. However, just the poor environment around that data, that particular information that is collected, we have poor transport, sample transport systems, where the sample is collected, where the specific lab that can analyze that specific sample is located. You have bad roads, you have lack of vehicles that can transport that sample to that particular lab. So you see that a sample that needs to be notified to the central level within 48 hours can take even a week. So imagine how much the disease would have spread within time, how much the disease would have spread. And with the insecurity, you will have to look for a staff that is willing to take the risk to transport that sample. And when you even find a staff that is willing, you need to have the financial backup, the financial motivation. You are not going to tell him, oh, this is a regular, 9-5 job. No, you have to go the extra mile. Now, if the facilities are not autonomous, the facilities depend on the central level authorization for them to do anything. So you see, they are unable to, they can diagnose, they can have the cases there, they can have the willingness to act, but they need the go ahead from the central level in order to make a decision at their level. That's why you see we recommended that things should be decentralized in reality, not in paper.
Yeah, and them long hours, as you mentioned, and tight deadlines sounds like modern academia research as well. It seems like this is where everyone's going, where we just everything has to be done in a very, very quick, they say timely manner, but it's not always timely because if you're trying to upload that data so quickly, the risk of the mistakes, as you've mentioned already, is much, much greater. And sometimes actually taking a bit more time, get more accurate results rather than rushing just because you need to meet a, like a tick box of making sure everything's there. But then you could be preparing for the wrong disease, the amount of spread is wrong. So
Yeah.
I don't get why health boards think that actually just because you got to, because yes, the incubation period could mean the spread, but you could get it completely way out, in terms of, I mean, like you mentioned, that, in the report, in the data was saying that there was Ebola and bubonic plague. It's like when there wasn't. It's like, well, you're preparing then for the wrong disease almost
Yeah.
you because the data is wrong. Thank you for watching today's episode of the IDRiM podcast. This is the first of multiple episodes with Kadia Susanna in the next 2 weeks regarding her paper from 2023. We're also, alongside this paper, we actually explore more about the African healthcare system and global healthcare systems in times of disease and crisis. We hope we'll see you at the next episode.